Yeah, good morning, everybody. I'm Olof Akre from the local organizers in Stockholm, Karolinska University Hospital. And I'm going to tell you about using HUGO RAS system for doing the RARP. Karolinska has been working with the HUGO system since September last year. And I'm going to tell you a bit about the technical sort of challenges and issues, about the setup, but also, of course, a bit about how we did the operation itself. So first, a bit about the patient. Can we go back to the first slide, please? The patient is a 47-year-old male with, he's healthy. He has a father with metastasized prostate cancer. The tumor he has is a T1C tumor. It's a PSA 3.7, ISUP2, so Gleason 3+4. Is taken from two guided truss-guided biopsies, one on the right side, as you can see, and one on the left side. There's also one positive ISUP1 biopsy from the left base of the prostate. Based on that, our surgical strategy was to do a bladder neck sparing prostatectomy, also sphincter sparing, no pelvic lymph node dissection. We aimed to do right-sided interfascial low bundle because the tumor was lateral on the right side. On the left side, we aimed for an interfascial high bundle, but also going closer to the capsule there if the surgical planes allowed for it. So let's have a look at the images. So not very clear on the T2 weighted images, but if we have a look at the top image of the ADC map, we see a clear diffusion, effective diffusion on the right lateral side, and that's the index tumor of for this operation. There's also shadow on the left side, but that shadow from that shadow, the PIRADS3 lesion on the left side, we had no positive biopsy. But as I said, one positive systematic biopsy on the left base. So I think we should start the movie, and maybe I can do it myself. Yeah. So in Karolinska, we normally start up with a posterior dissection. So we have done that here as well. So we're coming into the operation with a bladder neck dissection. I want to tell you a bit about the port placement in this procedure. We have applied the traditional sort of arch-shaped port placement also for the Medtronic HUGO system to imitate what we're used to, which is of course the Da Vinci surgery system. And we thought that we would like to have the same angles, so everything is sort of kept as standardized as possible, not to introduce too many variables at the same time, and we find this was a productive way to do it. So we have a port placement of the normal type with just an arch going from the right to the left hip, and the camera port is just some centimeter above the umbilicus. And one thing that is very much different in the Medtronic HUGO system is that the arms are longer on the external side, outside the abdomen. And so, on the other hand, the camera arm is a bit shorter on the inside of the abdomen. So, placement of ports should be done not too high above the umbilicus, because then you will have troubles reaching down to the prostatic area. So here we're doing the bladder neck dissection, as you can see, and we're on, soon to meet up with the posterior dissection plane of the prostate. I can tell you that the ports we use we can use either plastic ports that we dispose afterwards, or we also have a set of Titan ports that can be reused. A bit about the docking of the HUGO system. it is, I guess you have seen what the Medtronic system looks like. There's also a truck close to this building where you can go and have a look at the system, which is part a small short promenade from here. But as you probably know, it's more space consuming in the OR than the traditional system we've used with Intuitive. So docking is the angles of the arms is a bit more, you have to be a bit more careful in order to avoid external conflicts. So we have preset angles of docking angles into the patient. Okay, so here we have joined the anterior dissection and the posterior dissection, and we're going down and picking up the vesicles and the vasa. And as you might remember, we're going to do interfascial dissection on the right side and inter to intrafascial on the left side. I normally do the least nerve sparing first in order to mobilize the prostate as much as possible before I do the most nerve sparing to have as detailed exposure as possible of the bundle that I want to preserve. Detaching the bladder, we normally use plastic hemlock here as we've always been doing for the first bits. When we approach the prostate, we normally, or sometimes at least, and I tend to use the metallic clips there, the Esculap clips, because it's more precise. You don't need to drill your way through the bundle, and you can actually use the tip of the metallic clips to dissect your way closer to the prostatic capsule. So I really like using the metallic clips for doing for getting good control of the surgical plane, at least when it's some kind of nerve sparing. So as you can see, we're using the scissors and the Maryland here. We also have a Cadier forceps holding the vasa and vesicles. And we also, of course, later on use a needle driver. Yeah, so here we're finding the interfascial plane on the right side. And I think pretty much the take-home message of this RARP with HUGO talk is that it's pretty much business as usual. There's not much differences once you're in the console using the HUGO system instead of the Da Vinci surgery system. And I guess that's the best thing you can say, that you feel like you're at home when you use this system pretty fast. The knife time is quickly approaching the same as for the Da Vinci system. So I think you're up and running pretty soon. I think the problems for us have been training and having good continuity of the OR teams of OR nurses and nurse assistants, because it takes some time to get all the teams in such a large hospital as Karolinska up and running with a new system. So I would advise you that are going to start with Medtronic system to have a good continuity at the first operation, but then very quickly move on to get all teams up to speed using the new system. Otherwise, you might restrict the number of procedures that you want to make. And as a former head of department, I know that you always want the numbers of procedures to increase pretty quickly to make the cost efficiency work for the hospital. But as you can see, it looks pretty much like it used to. Now that in this right side, I feel that I'm past the tumor. I can be a bit more bold moving in on the capsule, because I think it's good when you approach the sphincter to be to be close on the capsule if possible, and I think it's almost impossible to not approach the capsule once going to the sphincter, unless you want to have you risk to have a lot of side effects of this operation.
I know you perform.
Yeah.
Good morning.
Please.
I know that you performing in Karolinska Retio-sparing radical prostatectomy.
Yeah.
Do you have experience with this system or not?
We haven't tried it with this system yet. We haven't. So unfortunately not. But we have done cystectomies with intracorporal neobladder and intracorporal Bricker deviations, and Peter Wiklund is doing one on Friday morning with this system, and his operating time is pretty much that of normal procedures. So he did one on Monday now with a robotic time of 3 hours and 10 minutes for a cystectomy with neobladder and pelvic lymph node dissection, which I think is very good also with other systems. Yeah.
Okay. So your take-home message is that if you're able to use Da Vinci, you can perform without.
Yes. Yeah, very much. As a console surgeon, yes. I think the trick is the OR team, because the setup is different, the docking is different. The port placement, I think you should maintain the same, because it probably doesn't help you to change the port placement. But the trick is to get the setup in the room, sterilization processes. I mean, handling two systems, different instrument sets. All that is so it's kind of an administrative run-in period for using this system.
So the suggestion could be to perform simulation in OR before.
We have had very good help from the company Medtronic, and they have at least 1 year of a present startup specialist in the room. We have had even two for long times. So there is constantly a startup specialist and a technician available. So that part is working well. So it's more about the local OR teams that you need to have a strategy in order to get up to speed soon. So I'll just comment here that now on the left side we should do a high bundle, more nerve sparing, and I started sort of interfascial here to make sure that I was in the right plane. But now that I've passed the base of the prostate, I move in and go mostly intrafascial here, because it feels that I can safely do so. Yes.
What about the camera definition, the 3D vision?
Okay. So yeah, that's really one thing that I think is great. Actually, I think the resolution of the image. Yeah, I mean, now this is also a file that we're showing, so we don't have the same resolution. But to me, there is no image in laparoscopic surgery with such a good resolution as I've had from this system. So it's really good. And I can also about advantages with this system. I think the scissors here are very sharp. They are really cutting well, never chewing anything, which is really good. Very distinct scissors, or shears as they call it, Medtronic. But so they cut really well. So that's another, and I think another thing with this system that is, if we're talking about potentials and assets, I think it's the fact that you're watching a screen and you can watch it together. So if you're learning, if you're teaching, you're watching the same screen, you can point and discuss. You're not in this closed world of a binocular. So I think that's an advantage also for teaching. But the three-dimensional view, now we can't experience that here, but the three-dimensional view is kind of a bit different from what we're used to. So it's more feeling of depth. Sometimes you feel it's much deeper than you're used to. So here we're doing the apex, as you can see, and we should do sphincter sparing. So we try to dig out the sphincter from the notch of the prostate, being a bit trying to get as long length of the urethra as possible. So this guy was born in '76, so he's going to live with his potential side effects for a long time. So let's hope he will be continent. I haven't seen him. This was done in mid-April, so I haven't seen him. I've just seen the report from the pathologist, which is saying it actually was an upgrade to ISEP-3 with 80% grade 4 tumors and cribriform patterns. No prostatic extension, so PT2, but negative margins, luckily. So I was going kind of close to the capsule because, according to the radiologist, the risk of extraprostatic extension was a 2 on a 5-degree scale, and if it's 3 or 4, we go a bit further from the capsule. But in this case, went rather close on the capsule just because we knew that the risk was rather low to have it. Yeah.
What about functional outcomes? Do you see?
With
Did you
this,
see the patient?
It's too early to say.
Okay.
But
How long
just with the optics are okay so far. I mean, no difference. I can see no difference in terms of positive surgical margins, and there's no clear sign of any difference in functional outcomes at this moment. But still too few and too short follow-up since September last year to say anything, for sure.
In what post-operative day do you remove the bladder catheter?
Sorry?
The bladder catheter.
Yeah.
In which day?
So we normally remove it on the day 10.
10?
Yeah.
After?
So they go home the day after. This guy, he went home the day after the surgery with the catheter. And on day 10, he returns and we remove the catheter.
Okay.
Yeah. Sometimes 7 days, but rarely earlier than 7. Say 7 to 14 days, depending a bit on what the bladder neck looks like and so on. Yeah. But we send them home the day after. I think almost it's like 95% of the men that can be discharged on the day after surgery. Yeah.
Great. Also a patient that perform lymph node dissection?
Sorry?
Also in patient that undergone lymph node dissection?
Yes. No difference. I mean, obviously, we have infected lymphocyte and so on, but they often come back later on. So it's rarely a problem in the immediate postoperative care. I should say. Although, of course, there are a bit more, potential of blood loss and infections also during the stay. So yes.
Do you remove transabdominal drainage in postoperative day 1?
No, never drainage.
Never?
Never.
Good.
I haven't seen it in many years, actually.
Good. So do you have a percentage of lymphocyte, postoperative lymphocyte that require interventions or not?
Yes.
More or less?
I don't have that figure on the top of my mind, but I know we have like a readmission rate in this group for infected lymphocytes, which is, I think it's around 3 to 5%. I'm not entirely sure, but I think it's around that. I checked it like 2 years ago, and I remember we saw a readmission rate in that group was around 3 to 5%.
Thank you.
Okay. So we're doing the anastomosis here in the traditional way. Nothing special, no Rocco suture on this patient because it was a bladder neck sparing. If we do not bladder neck sparing, if we leave some bladder on the prostate because it's a tumor that is risking to go into the bladder neck, then we are more prone to do the Rocco suture to tie down the bladder down to close to the anastomosis, to not have tension. Yeah. Otherwise, I tend to do as few stitches as possible with a good adaptation. Yeah.
Is it a barbed suture or not?
Sorry. Barb suture. Yes.
Barb.
Yes. It is. It's the quill suture.
Okay.
Yeah. So this prostate was 30 grams. So it's an ordinary sized prostate. And I'm waiting to have the post-operative PSA. I don't
Okay.
have it yet, but
Today.
it was pathology
Very-
says it's radically removed, so hopefully it's also undetectable PSA level.
What about sexual rehabilitation?
Sorry?
Do you have protocol for sexual function after radical prostatectomy?
You mean to rehabilitation
Yes.
protocols? Yes, we have like a ladder of different measures. So starting with sildenafil, moving on to Bondil, moving on to Cavaject, and prostheses in the end. Yeah.
Okay.
But we have the urotherapists and the nurses
Specialized.
are working mainly with that and coming back to us when they need prescriptions and so on. Yeah.
Okay.
We also, during the follow-up, we follow up with a PSA for nowadays in Sweden. We stopped to check PSA after 10 years before, but nowadays we're actually continuing PSA checks annually for all patients. Basically indefinitely. But after 2 years, we let the primary care physician do that follow-up, and we send a letter to the primary care physician and the same letter to the patient, so they both can govern the process. Because sometimes we had primary care physicians that didn't send back the patient with an increasing PSA. So we let the patient also take some responsibility. I think that's a good idea. Yeah. So we're soon to finish here. I just think some words again about the HUGO system. So I'll sum up and say that I think the main pitfalls here is not about the console surgery, but about setting up the teams and getting up to speed with the sterilization process, with the training good teams, and ideally having continuity in the OR teams. I think at this point. It's now more than 20 years since Da Vinci came, and the world of regulations and rules have changed quite a lot. And I guess that Medtronic has had to respect a lot of more regulations. And so I would say that there's some safety layers on this system that we are not used to. And I would say that to me, safety. The best safety is the machine that does exactly what you want it to do, not asking you, are you sure that you want to do this now? We are feedbacking, and with a lot of good communication with the company to reduce the amount of safety layers, because we think it's unnecessary, because it will be a bit time consuming. You lose 10 minutes here or 50 minutes there in the end. I think they're working hard on reducing like technical issues that slows you down. But I think our operating times now are pretty much where they are with the intuitive systems as well.
Do you know if in Udinge they have a HUGO system to perform nephrectomy?
We have let's say we have 4 Da Vinci systems and 1 Medtronic HUGO in Solna, and then 2 Da Vinci XIs in Huddinge. So in total, the hospital has 6 Da Vinci and 1 Medtronic HUGO.
The HUGO is just for urologists, or
So far, we're waiting for the ICG because the gynae cancer surgeons are eager to start. But they want the ICG to be working, and there's been a delay in the delivery of that, so we're waiting for that. But as soon as we have the ICG, the gynae cancer surgeons will also start up with their procedures here. And I think in the end also colorectal surgeons will be working on this machine. But we will do it urology first, because we are the most curious people, most technically adapted, and then the gynae surgeons, and then the colorectal surgeons. Yes, so we're finishing anastomosis here. Yeah, so to sum up, we're happy. We thought we should try the system because we want to be the people trying the new stuff at Karolinska, and we did so, and we're happy we tried, because we think it's successful so far, and we're looking forward to expanding with this. Yeah. So I think we just tie the knots here and pull down the catheter, and the prostatectomy is done.
Okay, thank you. Do you just one more question? If you have something like air seal.
Sorry?
Do you have air seal? Do you use air seal during this procedure also with the HUGO system? Or?
Yes, we do.
Okay.
Yeah, mostly, yes. We have several of those, and we use them mainly, so we can go down a bit in the pressure in the abdomen to like 7 to 10 instead of 12.
Okay.
To have the same.
Do you usually have pneumoperitoneum at 10? Usually, do you have pneumoperitoneum at 10?
Yes, with the air seal, I go with 10. Without air seal, I go with 12 mainly. But I know we can go even lower. Okay, so catheter is pulled back and everything is done. So I should thank you all for the attention.
Thank you.
So much. Thank you, Flavia.